Welcome to 60 Minutes with Željka. Željka is with me today from botiss biomaterials. We're going to talk about socket management, what happens when you extract a tooth, and what we can do to improve the healing and to have a better aesthetic. So we're going to have a nice chat about it. We're going to talk about the techniques. We can also talk about some of our products, but we're going to really go into the details of the clinical aspects and the technical aspects of the product. So it's also a chance to get to know Željka, who's been in botiss how many years now?
Almost 10. Almost 10.
And because we started, there was a time where we were working at the beginning. You were in different departments. I was doing education. So maybe you can tell us a little bit about your life in botiss.
Oh, yeah, it's a quite nice story, pretty much. So, yes, it is now around 10 years. And I do remember you before and now coming back. So this is really nice. Yeah, I was pretty much always in research and development because this is somehow that is always my love and it's something that drives me all the way through the work. I was in development of the new product and pretty much in our development of the newest products that are even now, some of them on the market. But I was doing some animal testings, implementation in animals, Calvarian models, subcutaneous models. We were traveling, doing implantations and also histology because I am professor of anatomy and histology. So pretty much histology is one huge love that it is. And we were really discovering lots of this tissue response on each of biomaterials that we have, and membranes, grafting materials. So I was doing lots of histology and lab work.
Before botiss, so you're expert in histology and now you're moving towards, more product management. But what did you study before? What is your background then?
So pretty much I have very often question, are you a clinician?
Yeah. Right expression. Yeah.
Well, I'm not clinician. I'm a scientist.
Perfect.
Yeah.
I'm a chemist.
Yeah, I'm scientist pretty much. So I did finish molecular biology, but then I switched to medicine a lot. And then I did my PhD in medicine. I did some exams in medicine. So then I started to be assistant in medical university.
All right.
I did some exams more. And then I did my PhD in medicine in
and you
field.
Do mini surgeries and stuff?
Of course, yeah.
Okay.
And then we switched to the PhD. So I did a PhD in anatomy and especially on bone. And bone is huge part of my focus for over now 20. Can I say how many years? Please don't.
But
I'm young, but 25 years of experience with the bone histology and bone remodelation. And this was part of my PhD also. And I stick to the University of Medicine. Then I switched to the University of Stomatology. And I'm now associate professor and teach anatomy and histology for stomatologists.
But now you mentioned bone. So especially people who are not involved in dentistry or not experts, they tend to think that bone is there. You're born bone and it's a solid, static tissue, but it's not like that, is it?
It's totally not like that. It's organ. It's one of our organs. So it's very beautiful. It's organ and it works all life, till you are growing. It grows with you. But when you are then in puberty phase, how to say it stops with growing, but it remodelates all life.
What does it mean remodel?
It means that it has some certain cells that can reduce pieces of bone and one that can push the growing. So you always have growing and resorption, growing and resorption through the whole life. It's constant remodelation model. So everything impacts on it. So if you are a little bit fatter and stronger and you have too much force on the bones, they will start to be stronger and they will remodulate to have purpose to feel this body or to stick to this body, to take the weight. And if you are not, they will remodulate differently. So through the whole your life, they remodulate all the time.
Pressure is important, right?
All the impacts, hormones, pressures, cytokines, vitamins, so many things influence on remodelation.
For today's conversation, the pressure, I think, is one of is a nice connection to what we're going to talk next. Because, of course, if we go to the mouth, pressure coming from chewing from your teeth will reinforce the bone. So what happens and why is important to be careful with it when you remove a tooth? It happens to the whole mouth, mandible, etc.
Yeah. So it's quite lots of science behind extractions of tooth. It's so many publications out, beautiful ones, like one from Buccal that is explaining how each extraction little bit reduce the bone. So pretty much whenever you extract the tooth, it's some kind of damage on the bone. So bone needs to heal. And first step will be healing pattern. So first blood comes. So this is the first weeks of healing. Blood comes in the depthness that we have. So we provide ourselves a hole where the tooth was.
The socket.
Yes, socket. And we get first blood there. With blood, it's first step of healing. So cells are there. They start boosting the vessels. They are forming new vessels. They are forming healing pattern. They want to provide the place to fulfill with the first soft tissue. And then in the next steps with the bone.
Yeah.
But what is happening is that pretty much the whole life, and even clinicians now in dentistry, they are fighting with the soft tissue. Soft tissue is such a strong organ also.
Yeah.
Because it puts always a pressure, constant pressure on a bone. So if you remove the tooth and pressure of the soft tissue goes and goes and goes, it will lose the volume of the bone.
And why the volume is so important to keep the volume?
It's very important for us because every change of the volume changes space between tooths that you have there. Yeah. And also space the volume or losing the volume where you will maybe need to replace further with a new tooth. You cannot be without tooth all the time with holes inside. Yeah. So, and the pressure is very crucial. The pressure of the soft tissue, and what is the most, biology is really important there, is that soft tissue grows fast. Yeah. Bone, not so much. So you always need to give a time for bone to grow.
Yeah. And that's the same reason why, it is a different topic, which we'll probably cover some other time. That's why in the GBR procedure, you need to keep space using membranes, etc., etc. But that's another topic. But so let's go back to what happened. Let's say that we are in the aesthetic zone. I remove a tooth. Okay, there will be immediately some response from the body. But what happens to the bone and to the aesthetics if we don't do anything?
Yeah, if we don't do anything, this is a quite problem that I have, and somehow it starts to be almost like standard, or people start or not start, they are still not doing anything. And for me, it's very unclear why, because science and papers showing leaving socket dry, like we say, or leave it socket without any treatment in that step of extraction leads you with such a problems after. You lose the volume, then you need to make an implant maybe further, and then you need to make an extra surgery, extra money, extra time. It gives our patients situations that they need to spend so many money in the end to achieve what could they achieve in the same time of extraction.
Okay.
They lose the volume because when you extract the tooth, and especially in aesthetic zone, you lose the volume.
But let's
for implant, for bridges. Yeah. So if you lose the volume, the aesthetic for bridges, aesthetic for implant will probably not even be possible. But for aesthetic for bridge also, you lose possibility for long-term good success.
So we've been, as botiss, we've been working on a socket management campaign that will come later. So can you tell us the three major situations and what it's been done today in those three cases?
Yeah. Well, we can divide it somehow as a three cases, like you said. I like it. Yeah, simple, like a socket 1, 2, 3. Socket 1, simple situations when you have all the bone around. And after extraction, if you really have thick bone, and some consensus says that it should be at least more than 1.5 millimeters.
Okay.
And if you have this,
Case scenario.
this is the best case scenario.
Yeah.
It's not so often, to be honest.
As usual.
As usual. Life is never easy. So this best scenario, yes, if we treat with, in my opinion, best products could be here as a collagen or colla fleece or something like a sponge, collagen sponges, where we'll bring this blood inside even more. This will be the treatment for the socket type
So when
1.
let's say when the socket is intact, the only thing we need to do is to protect basically the clot, and that's formation of vascularization and healing. So that's the easy part. But you said that this happens, so that socket is not so often case. So what are the other cases where you have to?
Yes, so the problem is usually if you already need to extract the tooth, probably is because of some inflammation. High inflammation eats the bone also sometimes. So you lose the bone.
A friend of the bone.
It's not a friend of anybody, neither the soft tissue. So we have a socket type 1, like I said, not always the situation, but socket type 2, where I will say something where we have compromised, usually this buccal plate. Or we say like this area, external area, and aesthetic zone. This line is very, very crucial, very study focused, so many science behind that if this line is stiff, strong, it will be stability for the implant in long-term life. So this socket, if it's compromised, we need it protected. Protect the buccal plate, we need to protect the stability, we need to treat this line of the bone. It will be our first line of the defense, how to say, in the end. So this is a compromised socket. And you have a socket where you don't even have this wall, because usually anatomically it's very thin.
Yes.
So if you extract the tooth, probably even this thin line will be so fast resorb. So this is the situation of the socket type 3, or like it's really not having a buccal plate at all.
It's the worst case scenario.
Yes.
And from what I understand, type 2 is the most recurring?
One type 2, and yes, and type 3 could occur, because type 2 pretty much leads to the type 3 if you don't do anything, certainly.
So, of course, today we're going to talk about botiss innovation, NovaMag Shield, and what to do with it, and how to use it in the socket, what indications, property, etc. But what is normally been done, or it has been done so far in, let's say, type 2 socket? What is the procedure? Do we use biomaterials? Do we use bone? What kind of bone grafting, etc.?
I hope we use bones and grafting and membranes. We call this as a socket preservation step. I do believe that most of the clinicians goes on this pathway to, if you already extract the tooth and do this simple one step of putting a grafting material and membrane to close it, to preserve it, to preserve the hole and volume and the stability, you save yourself a huge time of the work. Especially after for the implant, especially for the bridge and anything what you will do after. Also, you preserve this volume, what is crucial for resorption, because the biggest resorption of the socket is always in first 3 months and then 6 months rapidly. You know, study shows that from the paper, you can see that percentage of resorption goes in first 3 months like 20% in horizontal, but till 6 months, double 60%. So if you don't put here, and I really adore our Cerabone Plus, I need to mention one product of ours, it's Xenografts, and it's with hyaluronic acid. So when you put a few drops of just blood inside or saline, it doesn't matter. When you mix it, you have a sticky bone. Such a simple like application for treatment, extract, and for fill the hole or socket with something that is long-term stable. Because I don't know if you know, but I think you know, you know that our cerabone, it doesn't resorb so fast. You see, you will have something for long-term volume in this kind of socket.
That's the main goal of, in general, bovine bone grafting, because
Yeah.
you don't resorb. And with botiss and cerabone and cerabone plus, we have even a long-term stability, or longer than other products in the market. So it's ideal, especially, I imagine, that what you think about that in the aesthetic zone, because then
Of
we
course.
draw the profile with cerabone plus or cerabone, and then we keep the stability there, so we kind of fight this resorption that you
Of
talked
course. And especially with Cerabone Plus, I think this is such a machine product from the ones that we had before or they are on the market, because it has this hyaluronic acid. Not even handling. Like I said, yeah, it's cool. It's easy to manipulate. Like you drop wherever you need, and it doesn't flows like particles everywhere. You don't make so much mess. And everybody needs to clean after. But it has this hyaluronic acid.
But some clinician would say that, yes, I like the bovine bone grafting materials, but I prefer something more biological that remodels, like an allograft, like maxgraft.
Yeah.
So what is the idea behind maxgraft? Is also a fantastic biomaterials.
Oh, yeah.
Allograft, which, it will have real bone remodels more naturally. So do we mix them, or in some cases we use one, the other? What is your opinion about it?
Well, Allografts, in my opinion, is golden standard. We say autologous bone is a golden standard, but next, what can be from the box, it's maxgraft in that case, or Allografts. Lots of clinicians that I'm working with using always this kind of mixture. And whenever you go inside the envelope, they treat and use allografts because they don't need to go over the volume, or they are not concerned to the volume resorption. They want to have this remodelation of the real bone. And if you go more over the envelope of the envelope or of the bone, or lined with a volume,
Yes.
you go with more percentage of Xenograft, in this case Cerabone Plus. And what is really also cool, you can use Cerabone Plus and put a little bit of maxgraft inside, mix it all together, so everything is sick. Then everything is very sticky all together.
That's good. So then, okay, so we have a socket, we need to protect it, so we use bone grafting material, Cerabone Plus, maxgraft. Do we leave it exposed, or we need to use something to cover it?
I do believe that covering is the best option here. We don't want bacterials to come inside the socket. We want to prevent them. And also, I said before that soft tissue grows much faster than bone. You want to stop soft tissue to go in, to give time for bone to grow. So putting a membrane, it will make this kind of small barrier, and it will give time for bone to be produced and soft tissue to go on top of it.
Yeah.
So here, yes, we have quite a big portfolio. Like both is 360 degree. You can choose whatever you want, whenever you want, for every indication. So for collagen membranes, of course, we have a huge portfolio, and also collprotect, and we have adjacent. We have from pericardium, from the soft tissue, from dermis. So quite big source to choose. And of course, I would like to mention here very beautiful product that I like, and we will celebrate even 15 years of it.
Of course, I'm a fan of the product.
Yeah.
You're talking about mucoderm.
Yes. So mucoderm is like a soft tissue replacement or matrix that you don't even need to close with a pellet. You don't need to do or torture your patient. Immediately close the socket even with this, and you boost bone and soft tissue in the same approach.
Yeah. That's one of the strengths of botiss, that you can choose different products for every single clinical situation, even in case, for example, you have patients who might not want to have animal products or human products. So, for example, you could have, in a situation like this, a synthetic alternative like permamem.
Yes.
Which is I love that product because, first of all, it looks cool. It's a blue product.
It's like a scarf.
Exactly, color my scarf. And then it's easy to use. It's a fantastic product. So this is what we've been talking about, when we talk about socket management, resorption, how we combat it, fight against resorption. And this is basically the standard.
Yes.
But now, because in botiss we are fond of innovation, we come up with new ideas. Now we are saying we have something new.
Always.
So, what are we talking about?
Sneak a peek. No, all these products that I was mentioning, they're on the market for some years and years and years, and even this 15 years. So, but we have innovation that change all of this a lot. And you know how big innovations in history change lots of things. Yeah. So here we have a shield. Such a cool name. I like it. And it's really a shield. You shield yourself a buccal plate for long-term success in such a simple technique, in such a simple approach, and you protect it for volume and for bone quality. And also, what is quite cool with this product is that it has some properties that others doesn't. So we have something strong. It's metal, but fully resorbable.
Yes, that's the cool thing, is that I remember when the first time I showed NovaMag Shield to a doctor, and I mentioned this is metal, and of course it's clear because when you use it and touch it, it's clearly metal. But then when you add to that this is resorbable metal, they go, wow. Yeah. This is such a new concept, and today we will continue with understanding a little bit about the shield technique with NovaMag Shield, the properties, what is the metal we are talking about, and what are the advantages. Now we're going to focus on our innovation. NovaMag Shield is a new product. It's been on the market for a few years already. And we want to understand why Shield in socket management is a plus. What is so cool about it, and why is it an innovation? So Željka, why Shield?
Why Shield? Yeah, this was a quite journey to develop this product. I'm really happy, and I was in such a nice group of colleagues from botiss with development of this product. It was quite a long journey, around 10 years. And we finally have now something on the market that has purposes of something rigid, strong, but fully resorbable like collagen. Yeah. So we are opening new indications, new techniques, and quite innovative what we figure out now in the last 2-3 years. And it starts to be such a huge boom is shield technique, using our shield in a socket management situation. So
let me do a step back. How does it look like? When I open the box, how does it look like?
Metal.
Metal?
Yeah, very often they tell me like, what is this? It's like something for Rengen pictures, to doing Rengen pictures, or what is this? Or like, I'm buying biomaterial that is metal, what? Yes, it is. It looks like as a shield, like a shape like 10 by 20. And we are also now in a step that we will develop new sizes, even for specific implementation, specific indication. But it's a metal shape like a shield, and you still can cut it, shape it, smooth it. You can make convexity on it, such a nice, and it stays convex like this. You shape it, you still can pin it. You can pin it with resorbable screws or non-resorbable screws, and you can use the same product also with Xenografts, Allografts, collagen sponges, pretty much all the products.
I mean, Željka, you are keeping us like, in the dark, but let's say it. So NovaMag Shield is a resorbable metal, magnesium. We're going to talk about the property of magnesium and why it's so special later. But now let's talk about, so I opened the box, right? It has a shape of a shield, NovaMag Shield, is as mechanically strong.
Yeah.
So, but I can still cut it or shape it.
Yeah, so it's not like titanium, titanium is very stiff.
Yeah.
How you place it, how you do it, it's not so easy to manipulate. Also, if I compare titanium meshes or reinforced membranes, titanium is strong. Yeah. This one is a metal, but still you can, like I said, shape and cut, but it still provides this stability.
NovaMag Shield is already cut into shape so that you, and we're going to get there. So to apply it, you just tunnel it.
Yeah.
Okay, let's talk then about exactly how this works. So we've been talking about socket management. So why shield in socket management and when?
So pretty much we touched the topic about 1, 2, 3 sockets in a previous episode. So pretty much when we are touching already the problem with a buccal plate, too thin or compromise or not even having a bone, this is where shield comes.
Okay.
Pretty much. There are several techniques already that are very famous one with different products, like with collagen ones. You have this either, ice cone technique, cage techniques for non-resorbable things with these non-resorbable members. So many other techniques are already there. But all of them, I think it takes lots of times to do them. It needs soft tissue management to know, because you open a flap, you put a grafting material, you put a collagen, you fixate the collagen, you close the flap or suture it. Soft tissue management, it's really hard if you are not experienced one. And if you decide to not do soft tissue management, then it has this kind of ice cone technique that goes from the inside of alveolus or area where the tooth is. Inside, again, you put the collagen, you put the grafting material, you close it, then you suture it. But they all go from inside of alveolus. What I am concerned is that whenever you go inside of alveolus, you lose this extra part, this volume that we were talking about, especially in aesthetic zone. You lose this buccal volume, buccal plate, and buccal convexity. This is what we need and concern, or we need to focus on.
Let's do a step back. Walk us through exactly step by step in the clinical procedure in the cases we've been talking about.
Yeah, we already did publish some even publications, cases, and flyers on this topic. And this one I really like. It's such a simple one. And pretty much it shows you to do it step by step. You know, these pictures for dummies, I adore them. I adore them. You know, I never read manuals. I just read if there are the pictures. I look through the pictures and I know everything.
Exactly. This is perfect.
So we make it as the pictures, you know, simple fun. If you do extraction, then you lose the bone if you don't protect it. But if you do this one extra step and involving shield there, you protect the volume. But just to explain technique by step. So after extraction, we go with this technique externally from alveolus.
Okay.
Why? Because you want to protect even this part of the bone that you have there. If it's a little bit compromised, if it's thin or anything, you want it. Biology says that you should have it, of course, and we want to protect it. So what you can do very easily with this, because it's rigid, if you detach first soft tissue from this part and tunnel shield, you provide yourself shield from down all the way to apex of the root. And why it's so good as a technique, or why it's different if I compare with tunneling any other product, it's very easy to tunnel something that is rigid. You can see on the case that, for example, I can show you the case with like this one here, or is the, you see, he just provide the space where he needs, tunnel it fully. If you tunnel collagen as a comparison, first of all, it's not so easy to tunnel. It flows, it's soft. Collagen is really soft. Second of all, you are never certain that you tunnel till the end or to the apex, because again, it's such a soft and you don't see it, you don't feel it. With this, you tunnel all the way down to the residual part of the bone that you have. You tunnel it and you place it. So, and what is the beauty of the technique? You don't need to fixate.
So wait a second. So we don't need to do fixation. It
No.
stays there in place without fixing.
You don't need to do flap.
Okay.
Flapless. You don't need to do fixation. Fully fixate, because it's so rigid by itself. it doesn't need fixation.
Yeah.
It's fixated, how you tunnel it all the way down. It's fixated by the apical and mesial bones, so it stays there. And if you play even nicely and make it convex, it stays and makes you this stability already of the soft tissue, like you can see in a case.
So we are protecting the area and maintaining the space with no flap surgery, with no fixation, and then that's it.
Yeah, pretty much. So you can see, if I compare now standard procedure, flap, grafting, membrane, fixation, suture. First of all, I number so much products. I number so much time of hands of the clinician. And here it's really extraction, detachment, and tunneling. And this tunneling is quite nice, like I said, because it gives stability. It's very important to know that stability of shield comes from shield itself, not from the graft below. Usually, all collagen products or collagen membranes, they all have a stability from the graft below.
I see what you mean. Yes.
And with here, stability comes from the shield.
Because it's a mechanically strong resorbable metal. So you can really create a shape. And so you could create a convex.
Yeah,
exactly.
I joke very often, you just replace the wall that you are missing. Mm-hmm. Very often, even in Berlin now, we are just talking about walls. Yeah. So walls, every wall you are missing, Buccal, palatal, it doesn't matter. Where you're missing the wall, you can tunnel it and provide yourself a wall that you're missing.
In other words, what we're doing with Shield, with NovaMag Shield, is we create a temporary wall, which would be replaced by bone.
Yeah. And it will be replaced with a really good quality of the bone.
Yeah. I have to say, I heard from many clinicians that the quality of the cortical bone is unprecedented. But this is probably has to do with the magnesium itself, which we will discuss later on.
But also from the stability of the membrane.
Yeah.
Because what is happening, if you have something rigid, you don't have too much micro movements. Mm-hmm. And we talk already, micro movements are very important because if you don't have movements, bone can grow. Every micro movement, it makes problems to the bone, to our biology of the cells, biology of vessels. So if you have something more stable, it results with also quite nice outcome for the bone.
And is it really that easy?
Tunneling.
Yeah, well, you remember NovaMag Shield compared to previous techniques.
I show you already one case. I can show you several of them. It's quite easier to tunnel this than any other product, of course. And the outcome, how you will do closure from above, of course, it's different what you will do. If you will do immediacy or you will do delay or early implant placement, this is different. But certainly tunneling of something like this, it's much easier than modulating with all sorts of grafting materials and collagen. As a technique simple, but what I like the most, I think the outcome is quite different.
We've been talking about a metal that is strong and mechanically stable, but that resorbs. So the question is, what is this metal, Željka?
Oh yeah, this metal is magnesium-based shield for us. So again, the journey was quite long, 10 years. Oh, development journey. So like I said, I switched for so many departments. So it was research and development, new techniques and development. I always like this playing with the new toys, you know. This is the beauty of botiss overall. We have such a huge portfolio, and then I can play with so many products in our hands. So we play with grafting materials, allografts. We have allografts, Xenografts, synthetic grafting material. Then we have collagen members, non-resorbable members, and then we have even metal ones and resorbable ones. So many products that we still mixing, playing and inventing new ones. And I was quite in the department of new techniques and development when we were doing this launching and development of the magnesium. It was a journey of almost like 10 years overall, together with the other products in pipeline. But it was a journey from in vivo, in vitro, all the way to human We discovered so much. Yeah. It's so nice that the whole this journey went, and we discover more and more and more through this journey. We discover how it degrades, how it performs, how it behaves, and how the healing pattern is. And we discover so much things that help us now. And now, certainly, we are in the state of we are 3 years on the market. We have multicentric studies of our products because we have a NovaMag pipeline. We have also fixation system, membranes for big augmentation, but we have also this shield. And we have a registry. Together with multicentric study that combines Copenhagen and Hungary and Rome and Croatia. It's so many different places where we are collecting clinical data. And also we have a registry. It's like something like a real life data. So something that was very popular in Corona time. I don't know if you know, we were updating all the time results, what is real life data, what we are collecting. It's the same with Shield. So we are collecting all the time clinical cases, clinical data, comments from clinicians. We listen clinicians all the time. My what I really like is that listening clinician input and then combining with the knowledge of the biomaterials or science behind the products or science behind biology, combine these two together, this is where you grow pretty much. And this is how Shield growed. So development of all this indication, we have so much data on it, we achieve CE mark, and it is magnesium.
Let's do a step back because I'm curious about the journey. So we went, of course, from the chemistry, the science, preclinical, and clinical with magnesium. But magnesium as a material in other fields has been used even in cardio, other kind of applications. So can you tell us a little bit about before botiss innovation in the dental field? Magnesium was already in use for specific situations. Can you tell us a little bit?
Yeah, it's a huge science behind magnesium. It's such a cool material. And it is already for 5 years on the market from different companies in cardiovascular field and also orthopedic field for collecting.
Aspect. What do they do with magnesium?
It's more for stents, you know, like a syringe of the putting in the vessel as a stent. So to provide, again, providing a mechanical stability for the vessel so that it can flow the blood pretty much.
The resorbs also there.
Yes, but it gives the stability for vessel to heal through the time.
Nice.
So pretty much similar what we notice in cardiovascular field. And like I said, it's not discovering hot water. Magnesium, it's such a material that has a huge science behind. We are just from cardiovascular field, from orthopedic field, we bring it to the dental field. So we are the first company, and I'm so proud of it because I had a beautiful journey with my colleagues, Svenja and Patrick and everybody that I concern, not only colleagues, as friends. We had a journey of putting this product on the market. So we are the company, botiss company, as first having magnesium resorbable membrane and fixation system and shield on the market.
Very good. And but of course, I mean, magnesium, I'm a chemist after all. So magnesium, even before companies developed it for clinical use, magnesium is a natural element that the body uses and needs. Can you tell us a little bit about that?
Did you take a supplement?
You know, I eat a lot of vegetables, so I don't have magnesium. So.
Okay, I use supplement. I use magnesium regularly. Every day I use maybe different forms. You have this magnesium citrate and the magnesium older one because I do lots of fitness and I try to be healthy, and I have 2 kids, so you need to run all the time. Yes. So pretty much supplements of magnesium are so common. I think everybody is using.
Yeah.
So yes, it's an element that is present in oral food like you. Are you supplementing magnesium, or as a supplementing like me, directly magnesium? It's in so many steps on vascularization purposes, also muscular dysatrophies. That's why I'm using like for the muscle restriction of the muscles pretty much.
You feel very relaxed after taking
Oh, yeah.
for muscle.
Yeah, for spasms and these things, magnesium is also involved. In so many steps of everything in the body, pretty much, you can see magnesium everywhere.
Exactly.
Yes, and it's so present element. But for us, in that case, it's very important step that it's in each step of remodelation of the bone.
Yeah, that's great.
Yes. So what is happening? He is the one who can really boost this proliferation of the cells. You know, proliferation for like cells that doesn't know what she should be. She decides what she should be. It boosts that it can be osteoblast or osteoclast. So pretty much osteoclast resorbone, osteoblast grow bone.
Yeah.
But magnesium push like, and all these steps in remodulation, in proliferation of the osteoblasts or even more cells to be in that way. So for us, magnesium, it's very crucial that in all these steps, boost bone growth, boost proliferation of the cells.
Okay, so but walk us through what happens. So I take magnesium, so NovaMag Shield from the box. I tunnel it very easily, flapless, no fixation. Now natural biodegradation starts. Walk us through what happens to our NovaMag Shield within weeks or months.
So first of all, it degrades immediately when you open a pouch. So when you get the product and you open a pouch, already on air, it starts to degrading.
Okay.
So over the time, you could maybe even notice on a metal a little bit like white spots. Somehow it's magnesium salts.
Okay.
And this is what is really interesting for us, magnesium salts, because they are the one who are on all these lines of all these steps in our body progresses. But what is happening? You put in your body as a shield technique and provide yourself a nice buccal plate. It starts to degrade with blood. Also mixing with the blood, it starts to degrade. I like to say and explain degradation of shield in two phases.
Okay.
So one phase is this metal one. It's a little bit of like oxidation that we have. We say like hydrogen gas, and metal phase start to be replaced in a salty layer.
Yeah.
Then you have a second phase. This is a salty layer phase. We call it jelly phase. Metal phase, jelly phase. Why? Because some clinicians who had exposure or leave it exposed initially, they notice it looks first metal, then whitish or blackish, then they notice it looks like a jelly. Why? Because magnesium salts are a much bigger molecule. They need more time to be replaced in a bone or soft tissue. So they're also providing barrier function.
Okay.
But it looks not more as a metal anymore. It looks more as like a jelly phase. So jelly and metal phase.
And so how long does this process roughly last?
So from our dog studies, we know that metal phase, it's finishing with 16 weeks.
Okay.
So, but I do believe that still, like I said, these magnesium salts are still present. So degradation of the full membrane is a little bit longer than that time point. But in a healing pattern, what means this for clinician? Healing is a little bit different than with collagen.
Okay.
So you put the collagen, first of all, collagen is usually white membranes.
Yeah.
And white below the soft tissue looks pinkish, you know. And with magnesium, when you tunnel and magnesium or metal below soft tissue mixed with the blood, a little bit starts to be a little bit blackish and everything. So soft tissue can look a little bit reddish or lilac. So it looks, just the color is a little bit different. You could experience a little bit of swellings in that area, but not so much. Why? Because it degrades slowly. Magnesium degrades slowly over the time. And product of the degradation is hydrogen gas. It's very small molecule, the smallest pretty much.
Yes, exactly. It's the smallest molecule in that.
Yeah, and it goes through the diffusion through the soft tissue out. And especially if we put buccal placement, like buccal shields, soft tissue of buccal plate is so thin, so it goes out very easily through the time. But this is this metal phase. we notice that with Magnesium Shield, you can have this healing or color. It's different, maybe a little bit of swellings in first week or maybe 2, but the rest is pretty much all the other is the same.
And tell us a little bit, okay, so of course, one side of the story is that with NovaMag Shield, we create space, we have a membrane or creating a barrier, more correctly said. What is the role on forming the cortical bone? So why is magnesium a good thing there?
I like your word, a cortical bone.
Mm-hmm.
I very often get from clinicians that using magnesium, they noticing very strict line between soft tissue and bone.
With NovaMag Shield?
Yes, because first of all, it's very rigid membranes, so the line is strict.
Yeah.
So this line is strictly dividing soft tissue. Also degradation pattern, little bit do tenting of the soft tissue. So it gives more time for bone to grow. And I like to say, and I do believe, even though I'm coming from botiss, that not biomaterials making bone, it's space that makes bone. And if you nicely listen biology and provide yourself this convexity on a buccal plate, you give this space for this bone to be remodeled in a real bone. So in that case, what is happening with magnesium that it gives such a nice outcome of strict line bone. And very often on Röntgen, they can see like, oh, whitish. It's so whitish, it's so strong. They notice this cortical layer of bone that we can achieve. And very often I get, oh, sorry, I never get this with any other material.
And circle back to what we were saying at the beginning. So we've done a lot of course, studies, preclinical studies, also for the registration across different countries, which is obviously a fundamental step. And of course, now we are moving from preclinical to, as you were saying before, collecting clinical data. Are we doing clinical studies on NovaMag Shield?
Yes, we are.
Tell us a little bit about it.
Yes, we are running a lot of studies, to be honest. I think this product intrigues so much experts over the world, and I was privileged to be said that I'm in contact with all of them, direct contact.
Let me ask you something. So you've been, of course, in contact with many clinicians using NovaMag Shield. Thinking about, the interaction with the doctors, what is the most typical reaction when they see the healing and the bone formation?
So first of all, when they see the product, it's always like, wow. And very often it's a comment I think it's sometimes misleading in a way that they think it's a new titanium mesh. This is where I want to explain that titanium mesh, I don't think it's going in that direction as a titanium mesh. Titanium can be placed, and especially this 3D and mace, depending on a defect and everything. Here, you need to use what is the benefit of this product. Of course, it can be used for big defects, but because it's new, because the healing is different, and because the outcome is different, I always want each of them, and it's my suggestion for everybody who starts with this product, to start with the simplest, easiest technique, and even to start first with the posterior region and then come to the static zone to feel comfortable. Because not that everybody likes changes,
I mean, it is a new product. It looks different. Also, it looks titanium-like, but then it's fully resorbable. And of course, you need to get used to how the product behaves in your hand. The healing, as we mentioned, is different from a collagen membrane. But I was looking more for like a personal reaction. Like, what did they say? Tell me one of the cases where you thought, okay, this is a very cool reaction.
So first of all, like I said, changes are so heavy, especially with some clinicians who are not progressive or doesn't want to change their own techniques, their own ideas by years.
Exactly the same.
So often they say like, this function with this, why should I change it? Exactly. And then if I combine like 5-7 reasons why it's the change, is because you save time, its outcome is the better technique as a better, so you save time for the patient, for the clinician, for as a technique as itself, and then the outcome. So it's too many reasons why not to try at least. And then they try. And this is where it comes, this wow effect. I had lots of them even on WhatsApps, so I'm guiding them through the operation, and that's the beauty. I learn from them and they learn from me. And this is where we get in such a short period of 3 years on such a huge level for this shield development, is that learning together get us to this point. So they say, oh, if you use this technique, it's simpler in comparison to this. I know the outcome, I know there is, then they are sending me I have full phone of the pictures of clinical cases, Röntgen pictures, and then they get like Röntgen pictures, they're sending me, look this. I just put the picture says more than any words I need to say, and this is the outcome that is happening. But they have one beautiful, I have one sentence that I want to say, is that they say magnesium will rewrite bone remodulation. And I do believe it is. I really believe in this product. Like I said, I was in a journey of development, so I may be a little bit biased, like my child. But it's changing a lot. We are opening new indications, like also for sinus lift, for the big rupture of Schneiderian membrane. We are opening easy horizontal augmentation with just 2 screws and not whole sausage. So all this comes from this real life data, and all this opening new indication brings them easier life, and in the end, patient easier life, because we all know that if the patient is happy, everybody's happy.
Let's talk about a hot indication, immediate implant placement.
Oh, yeah.
Can we use shield in that indication, and why?
Yes. So pretty much immediacy start to be now like such a boom. Also development of new things. I think development of digital dentistry, possibility that you can put implant, and also wish of patient. I also, if I go to the dentist and I extract the tooth, of course I want to get out with a new tooth, if it's possible. Everybody wants this. So happy patient, happy life. But immediacy, it's hot topic, I agree, and very good option for everybody. You save time, of course. You provide the patient immediately new tooth. And very crucial in my opinion, here to involve shield, because, we are maybe opening new indication in that area that now if I start talking, many clinicians will maybe like, jump on it, that we are opening a Pandora box. No, we are just opening a new field of research.
Okay, let's do a step back. So I'm curious about hearing how with shield we are opening the Pandora box. But we're going to do this in a second. Tell us about how an implant is immediately placed. What is the normal procedure, and what are the advantages or the disadvantages or the conditions we have to be careful with when we do this?
So in previous episodes, we talk about these sockets types, 1, 2, 3, like having walls, compromised walls, and not having buccal wall or plate. So in immediacy, they say if you have a really perfect situation, all walls, thick wall more than 2 millimeters or 1.5 millimeters, you can do immediacy. Yeah. And then we come to the socket type 2. It's like if it's compromised, if it's too thin, like this 1.5 that they are mentioning all the time, they say you should not do it.
What would you do instead of immediacy in that case?
Instead, you would need to preserve socket preservation. You will need to do grafting and the membrane and preserve the volume. So you preserve the space.
So like in terms of timeline, so we are talking about, let's say, 6 months to wait for the regeneration. So
first you need to extract, augment. wait for 6 months or 3 months, depending which grafting material you are using, because we also have allografts. You know, with allografts, everything is around 3-4 months. With our Xenografts, you need to wait like 6, maybe sometimes 7 months, depending how big defect we are going. Because I do believe, again, I'm coming from anatomy, morphology of defect dictates everything. So in that case, all these two things are concerns. So we can talk about early or delay implant placement, but you have 6, so we are already talking now 4 months, 6 months, 7 months, and then implant placement. After implant placement, you need to wait again, integration of implant for 3-6 months or something, and then provisional upstairs. Oh, it's a quite...
So you've been saying that with a standard procedure, we have to wait for basically roughly a year or longer, because the compromised socket requires attention in order to be having the correct procedure and be successful. How does that change with NovaMag Shield?
It changed that we can use Shield in immediacy, immediately in a socket, even compromised walls. So what is happening now? In immediacy, approach is that you extract the tooth, you place the implant, everything in a flapless approach. Minimally invasive. This is the problem. If you have ideal situation, you can do immediacy. If we're talking about compromised situations, you know, make the implant immediacy, maybe something who is really experienced could go there as a journey, but it's favorable, or guideline says you should preserve and then do early or delay implant placement. And socket type 3, oh my God, preservation and then implant placement. But we are getting so much cases with the socket type 2 or 3 with Shield and implant that we are opening, like you said, Pandora box, or we are opening a completely new indication. Why? Because they are both flapless, they are both easy tunneling, and they are both providing stability in the same procedure.
Yeah, let me understand this, because it's going to be an interesting topic, I think. So, of course, there is a consensus about paying attention to the more compromised socket, because we want to have success. And there's a reason for that, because being a compromised socket, you want to preserve first and then add the implant. How can we do a safe procedure, immediate implant placement in a compromised socket with Shield? Why does Shield help us?
So in compromised sockets, they do with implant position, a little bit maybe changing position more to the palate or something, and they do grafting. But when you do grafting in such a small hole and small area where you do immediacy, it's not so easy to place grafting, and especially sometimes you will touch threads of the implant surface. So in that case, you just place it. But again, like we talked about previous episode, on first episode, biology will do everything. Even though you put implant or don't put implant, biology is always the same. Soft tissue is always the same. Soft tissue will do pressure on it so much. So if you do only grafting with implant and don't do membrane, or even do membrane but soft membranes, it will happen that soft tissue will do such a pressure on this crucial part, buccal plate, that it will resorb, and maybe you will not achieve in the same procedure these 2 millimeters that we are talking about, because all the studies shows in biology that resorption of the bone, it's crucial in first year of any procedure. So if you do immediately and then grafting in the same approach, resorption could happen, especially in aesthetic zone, especially in a buccal plate, and especially in this convexity of the buccal plate, immediately. What will happen? You will lose implant. And you don't want to lose implant if you already, money-wise, time-wise, patient-wise, pain-wise, you don't want to compromise implant that you position there and then lose it.
Yeah.
Because the treatment after that, it will be even more worse.
And that's why there's a consensus.
Yes.
So how is this changing with Shield?
So with Shield, we, like you can see in the cases, and these cases, and maybe several cases while we are talking now, these cases shows such a beautiful results and outcome in the same procedure. And all these cases, I don't know if you know, but we get award as together with Clinician as the best cases in several congresses. For also in SEPA for some congresses. NovaMag is very like award product in this case. Yes, we are collecting so much data on immediacy. Why? Because with such a rigid product, if you tunnel it, you are certain that you came for the apex of the bone. You are certain that you make convexity with the mesial bone. You are certain that you make the hole where you will put graft, and that graft can go easily tunnel in. And again, you can use cerabone plus like a sticky one that you can so nicely put it inside.
So is it correct to think this in terms of, okay, it's a compromised socket. I don't have the Buccal wall, or the Buccal wall is not there completely. So I use NovaMag Shield, which temporarily is going to work as
a wall.
And with weeks and months is going to remodel basically into a cortical bone. And that's why even in a socket that is not intact, we can do immediate implant placement. Is that correct?
Yes.
And walk us through the exact procedure.
Yeah, just before that, I want to mention something very crucial. People adore synthetic products more and more. You know, they don't want to use maybe animal sources. They don't want to use sometimes human particles or animal particles, so depending which animal. It's so many diversity, but synthetic ones, they want to use it. Synthetic ones that are on the market are usually non-resorbable.
Yeah.
Well, you have some products that are like non-resorbable with immediacy, but can you imagine to use something that is non-resorbable and you already placed an implant, you already provide the prosthetic, and then what? You need to cut the soft tissue to remove this non-resorbable product or membrane or even titanium meshes that they are with these implants. So it's such a nightmare for touching already something that we often joke, don't touch papillas, don't touch soft tissue, don't cut it if you don't need it. So it's very crucial. We have something synthetic, but it's fully resorbable. Yeah. So you can use something stiff in immediacy, but still it will be resorbed. So you are not cutting soft tissue, you are not performing second surgery, you are not touching this beauty of soft tissue. You know how they look like around prosthetic and this beautiful area. So this is important. You know how you place and replace this buccal plate. Like we are saying, like we are replacing walls. You provide a space, longer space, the soft tissue not collapse. And you make grafting material and give the time. You know that you are giving time with this volume for bone to be grown. And again, synthetic, fully resorbable, it can be without fixation and flapless. So I answer on all the questions for what are requirements for immediacy in the end.
And okay, you said that in this kind of indication, we are receiving a lot of clinical data.
Oh, yeah.
Are we organizing this clinical data to move towards a more systematic study? So are we running study to prove with stronger evidence that NovaMag Shield can be used in this indication?
Yes. We are running now 4 or 5 studies in that point of view, some of them in this early delay placement, because this is the only option for us to get trephine and to have a sample of the bone. And I have my personal problem, that I don't believe Röntgen pictures till I don't have histology, you know. And so for some of the studies, we are running this kind of socket evaluations of the bone with Shield, different kind of, is it sponge below, is it Xenograft or collagens, or depending what we are using as a grafting material and depending which morphology of defect is. But Immediacy, yes, we are running studies with the university in Lisbon also, and we are running a university in Chile. So what is quite nice is that we are opening this socket type 3 even as a crucial deficiency or not having buccal plate. We are opening in this indication to place an implant and provide stability with the shield immediately. So yes, we are running these 3-4 studies that I'm anticipating, I'm waiting to get the results, and I hope we are opening completely new indication now.
Okay, nice. So we are exploring all possible options within the 3 type of sockets with NovaMag Shield. What would be your message to a clinician that opens the box of NovaMag Shield for the first time? How should they start?
So first start, this socket management that we were talking about in previous episodes and everything is the simplest technique, and I adore it because I think in a dental practice each day they have at least 4-5 extractions and some kind of socket managements. And first of all, like I said, some of them they don't treat at all socket, they leave it just blood clot and sponge. I believe that if they add just one step of this tunneling and providing stability, please protect this buccal plate, because it's so many papers saying like buccal plate depends on implant, buccal plate depends on volume, buccal plate, it's all buccal plate. So if we protect it in that one step after extraction, I think for them, they will see outcomes so easily and they will know what to do after. But this will be the perfect indication to start. Socket management, is it about missing a little bit buccal plate? Is it a thin? Is it destroyed? And also sometimes when they extract the tooth, they butcher sometimes buccal plate because it's thin, it can broke. Save it in that step. You will be more than happy in the outcome after for the placement of the implant, like you will be, and also for the maybe bridge construction or volume stability. But this is the first indication that they can do so often, and I do believe that even a classical general practitioner can very easily start with this and see how it behaves. Because like I said, comparing with some other techniques and also soft tissue management and everything, maybe not everybody are so on the level, but this is such a simple technique and to try it. And of course, I think every clinician likes to have a new toy in their drawer. So if they start with something like this, I believe and I know, because it happens me so much times with so many clinicians, they will start trying the other stuff again after.
So you would say then extract the tooth and then just shield it.
Just shield it, pretty much.
Perfect. Good. Thank you, Željka. And we will see each other in other episodes, 16 minutes. We will have clinicians and other colleagues from botiss. So stay tuned.